Good evening. The American College of Cardiology and our NCD Academy partners, the World Heart Federation and the NCD Alliance, are thrilled to have such a diverse group of regional experts for this panel discussion on managing chronic disease alongside COVID-19. My name is Dr. Alan Fong. I'm the Vice President of the National Heart Association of Malaysia and the International Governor for Malaysia for the American College of Cardiology. I have with us this evening a great panel of experts. First, Dr. Zheyong Huang, who is the Associate Professor of Cardiology at Jongson Hospital in Shanghai, China. Dr. Dorairaj Prabhakaran, who's the Vice President and Director of the Center of Control for Chronic Conditions of the Public Health Foundation of India, and Dr. Carmen Auste, who is the Vice President of the Cancer Coalition of the Philippines. I think as we start this evening, I thought we might spend a few minutes sharing research underway on COVID-19, which may not directly be relevant of the theme of this panel, but nonetheless important implications for patients that primary care providers and other clinicians should be aware of. Perhaps I could start with Professor Huang. What are the latest findings from any studies underway in your country to better understand the impact of COVID-19 and or the viability of potential therapies?
Because the epidemic outbreak during the February in Wuhan, China, we have we have produced or conduct several clinical trials regarding the clinical treatment of the disease. However, there is no positive result concerning the treatment. As far as I know, there is no specific treatment for COVID-19 or the coronavirus so far. Just as other kind of virus disease such as AIDS or such as hepatitis B, it's very, very difficult to develop a specific treatment for such virus disease. So I'm not so optimistic for the treatment, new treatment for such disease. However, I'm optimistic for the vaccine development.
Well, thank you. So we are very grateful for the early hard work from research from China that provide us early knowledge of this condition. Can I ask Dr. Dorairaj about India in terms of any of the recent clinical trials or research on COVID-19 that you might want to share with us?
Okay, I would classify the research into 3 or 4 groups in India. Number one, in terms of the registries of COVID patients, to look at various manifestations, including cardiovascular, stroke, so on, lung manifestations, etc. The second is the vaccine trials that are happening. There are 3 main vaccine trials. One which is collaboration, the Oxford vaccine being trialed by the Serum Institute. It's phase 3. The second is the Indian Council of Medical Research with Bharat Biotech, which is a pharmaceutical company in India, and that is also entering completing the phase 2. Then there is another trial by a company called Zydus Cadila, and that's in phase 2. So these are the 3 vaccine trials that are happening. In terms of tests, various agencies have developed tests. So we're looking at all the 3 types: the conventional RT-PCR, the antigenic tests, and the antibody testing. Then we have the Cardiology Society of India is embarked on a big study to look at what was the difference in presentation, difference in complications, and difference in mortality in acute coronary syndromes between 2019 and 2020. So from March 15th onwards, they started recruiting patients, and they completed the recruitment on August 15th. They have recruited 50,000 patients so far, and the analysis is going on to compare. Very interesting data will come out of it to look at what are the differences in mortality, differences in presentation, the door-to-needle time, the symptom-to-door time, and so on. But in addition, we are also looking at unique things like what are the effect of the lockdown? Did the lockdown increase mortality? What are the effects of air pollution? Did air pollution, because it decreased, did it reduce the mortality? Those are the kind of things which we are analyzing. In addition, we also did a research recently on looking at COVID-related anxiety, depression, and overall feeling amongst the healthcare providers of all hues, doctors, nurses, and so on. That result also will be published soon. In a cohort that we have in 2 cities, we have interviewed people in terms of their attitudes, in terms of food insecurities that they have, in terms of how they are coping with the difficulties in accessing health system. So there are various different types of research that's going on, but the publications will come by the end of this year. Thank you.
Thank you very much. A broad range of research coming out of India, and we're looking forward to that. And Dr. Auste, what about in the Philippines? What do you consider all this research, or any update on the research done there on this issue of COVID-19?
Similar to India, we have categories of clinical trials and research that are being undertaken. In the area of vaccine trials, we have 2 general categories. One is the Philippines is part of the WHO Solidarity Trials for vaccines. And then there's a separate category which are being referred to as trials. And currently, we understand that there are already about 12 applications for being able to undertake these clinical trials in the Philippines. What we have done is, because there are quite a number of them, and because of the concern that there may be on-site field competition, so the Philippine Health Research Ethics Board, of which I'm part of the board, heading the Community, Family, and Stakeholder Engagement Committee, together with the Vaccines Expert Board, we have actually come up now with new policy guidelines for this situation in order to ensure that there is a rational distribution of where these clinical trials will be undertaken, as well as to ensure that there is a higher level of safeguards, not just for the patients, but for the community as well. And as you know, we had some negative experiences before with the Dengvaxia vaccine. And because of that, there is vaccine anxiety and hesitancy. And therefore, while this is just the clinical trials, whatever trauma some of them may have associated may still be there. So there will also be a public education campaign that will be undertaken prior to the start of the clinical trial. So there's a lot of collaboration among both the CSOs, government, and our experts, to the extent that the FDA has even asked the Vaccines Experts Board to first screen all of these applications, and then the PrEP prior to it being brought to the FDA for them to then decide these are the clinical trials that will be approved to be undertaken in the Philippines. In terms of therapeutics for COVID-19 treatment, we actually started some months ago convalescent plasma, first only in a hospital in Metro Manila. And then when there was also a surge in one of our major cities in the Visayas, the Philippines has 3 major islands, they also started doing it there. And so far, while this is not yet fully researched, but the anecdotal accounts have been quite positive. In terms of social research, similar to India, we're looking at the dimensions in terms of the impact on mental health, and CSOs are also undergoing various series of focus group discussions or actual research in order to find out how it has affected not just their lives, but their whole treatment journey as well. So all very interesting in terms of trying to capture the picture of what is happening, as well as preparing for treatment and eventual vaccines.
Right. Thank you very much, Dr. Auste. Again, a lot of great work coming out of the Philippines for us to look forward to. Now, may I go back to Dr. Huang in China? what would you consider the most important finding or the lesson that to have been learned from the COVID-19 experience to date?
And to control this epidemic, I think the most effective measure is isolation. The isolation of the population, the isolation of every person. During the outbreak of the disease, I come to Wuhan in Hubei province for 55 days. So I have worked there in a hospital for nearly 2 months. I think because in China we have effectively controlled the disease during a very short period. The doctor make a contribution for this good performance for this result. But I think the most effective measure is the population isolation. That means if a people was suspected COVID-19, we should send him to hospital to treat him. And when a patient was contact patient, we should isolate him in an isolate home, isolate room. So I think this is the most important measure or most important experience in China.
Thank you. We have learned from a lot of the early experience here, also in Malaysia, and developed very strong border control as well as isolation procedures, including admission of all suspected patients with COVID-19, and definitely keeping them isolated until they have been confirmed to be negative. So now I'm just going to go right through into the main session of the day, which is really on the NCD and during this COVID situation. So I think the COVID pandemic has really affected the NCD services globally. So it is important to distinguish between disruption of the acute care on the ward and the routine planned elective care. So, for example, in cardiology for acute disease, hospitals have seen a big drop in acute myocardial infarction and acute heart failure, for example. Do you see this situation reduce in China in the early phase, and has it now improved with the recovery of the population?
Yes, this epidemic reached its peak in China in the first quarter of this year. That means from February to March. In April, we start to witness this significant decrease in the number of affected people. So at present, there are only maybe 500 confirmed patients in whole country of China, including maybe 300 asymptomatic patients and 200 symptomatic patients. Therefore, the national medical order has already been brought to normal. However, we still on alert now. Dedicated fever clinics have still been kept in each hospital, and all patients with fever will be kept in isolation in separate room for further diagnosis or further treatment. Thank you.
Thank you. Can I ask Dr. Dorairaj now, the situation in India? Although I read about the cases going up in the third quarter of this year, but it seemed to see the cases now seem to be plateauing off. On the other hand, do you also see in your hospitals a reduction in all the acute admissions for things like myocardial infarction and heart failure and stroke?
Don't practice clinically anymore, but I will give a broad brush picture of what's happening in the country because I'm involved in with many of the organizations, particularly in terms of research. The first evidence of what is happening in terms of cardiovascular diseases and other NCDs came from a WHO study. In fact, WHO conducted a study in 55 countries, looking at what is happening in terms of screening, for example, surveillance for hypertension and diabetes. And they said even in India there has been a considerable decrease because of lockdown. People are unable to go. In fact, we cancelled a program on awareness called May Measurement Month, in which in the month of May we measure blood pressure in everybody using volunteers. And last year, we had data of almost we had collected data of around 350,000 people. But this year we cancelled it. The second hit is in cardiac rehabilitation because cardiac rehabilitation cannot take place. People cannot come. So there's been a lot of problem with that. The third area, as you rightly pointed out, is in acute care, where there has been so many of the hospitals have been converted to COVID hospital, and acute care has become very difficult. And anecdotal evidence suggests that there has been a 25% decrease in acute admissions because of the COVID. The question is, and the other thing that they have suggested is most patients who are coming to the hospital have severe illness, come with complications, so the mortality of non-COVID illnesses is higher. The other areas that have been affected include immunization, dialysis, cancer chemotherapy, and so on and so forth. So the second question that you said, whether India is peaking, India is not peaking like Italy or US or China, where you have a V-shaped relationship. It goes up like this and comes down like this. India is something like an inverted U. It goes up, but then it remains flat for some time, and hopefully it will come down a little later. So I think we have not actually touch the highest point. We are on the flat part of that U, and maybe after some time it will come down. Thank you. Back to you.
Yeah, that's great to hear. In fact, I agree with you. You know, May is the World Hypertension Day. Usually, we also have events, but we've also reduced or cut down most of these things during this COVID-19 session. Yeah. So if I ask Dr. Carmen Auste, what about in the situation from the cancer patients? You know, I think it is the treatment for some of these complex conditions for oncology may often require inpatient care and regular face-to-face visits with a healthcare provider. You know, how would you manage such cases in this season of COVID-19?
Well, the good news is that there has been a lot of adaptation that has been undertaken both by the doctors and the health facilities because, as you mentioned, cancer patients are immunocompromised and therefore should be no hospitals at this point in time. And as well, the cancer patients themselves have hesitancy to hospitals that are already identified as having COVID patients. And unfortunately, in our country as well, many of our bigger hospitals, which are the designated cancer centers, have now become COVID centers. So what the health facilities have done would be one, if they're really overrun, and there were instances before when they were overrun with COVID patients, they then refer them to other hospitals that can provide them both the chemotherapy that they need or diagnostic and imaging. The other one is that they also have, in a sense, we're moving towards universal health care, and one of the basic strategies there is network care between public and private hospital. So we're sort of advancing it in the sense that where the government hospitals that are utilized for COVID or even the private hospitals, where these facilities are not available, there are smaller health facilities that formerly were focused only on lab works or imaging, and this is where they're now referring their patients. The other one is where it is possible to change the IV infusion for chemotherapy to oral medications instead. This is being done as well. I think our doctors have also been guided by the guidelines from the American Society of Clinical Oncology, ASCO, as well as the European Society of Medical Oncology, ESMO, where they have a tiered categorization of patients from those that are highly critical to moderate or to low. And therefore, the delays in treatment, whether it is something that can wait and for how long, is actually guided and informed by these categorizations in patients. Two other things that we've done is we've also set up a policy early enough, latter early part of March, in terms of e-prescriptions, so that patients don't need to go see the doctor in order to get the prescription, and also be purchased by someone else. And we have also now legitimized and set up the platform, both from the government and the private side, for patients to be able to do teleconsultations.
Right. On this note, can you speak about some of the bigger issues outside the control of the individual clinician or the public health system? They are eroding health outcomes and may need to be a greater priority for policy and public health experts, especially coming from the oncology perspective.
Yes, one of the things that we actually done some months back was 25 organizations, both in terms of the medical societies as well as civil society and even academia, got together, and we had an open letter. In the Philippines, the body that has the oversight over COVID-19 and how to be able to fight it is referred to as IATF, or Interagency Task Force. So we directed this letter to them and as well to the Ministry of Health. And there were 8 important things that we requested, both from the IATF and from the government. But the main headline was that we needed to be able to have COVID-19 safe facilities and services, and that we needed to be able to safeguard the care and treatment of patients. So this is in terms of when they go to a hospital, to make sure that there's a separate entry and exit, to make sure that there's no cross-contamination that could happen in terms of imaging facilities, because as you know, when you have COVID, you have regular x-rays or even CT scans. As far as COVID patients is concerned, in the Philippines, we now have set up what we call a one hospital command, because as was mentioned by the two other gentlemen, there are some hospitals where more patients would be there and others where maybe they still have space. So through the one hospital command, they're then able to say, this hospital is now full, but you can go to this other hospital. The hope is that eventually this can be done as well for non-COVID patients. On their own, the doctors and the medical societies and the civil society are exchanging information. So we can say that this particular hospital, the onco unit there has closed, but this one is open. Or there's no more radiotherapy facilities there, but it's available there. So this type of referral system is now ongoing from the whole of society, but we still want government to then be able also to have a parallel setup for that. Of course, the biggest challenge now as well is financial in terms of patients, because as you know, in Asia, I think we have the longest lockdown since March, and especially in the capital city, where you have 14 million people and 70 municipalities, the lockdown to extent have been what we use letters rather than numbers. So we have ECQ, which is like the extreme community quarantine, moving to moderate and moving to general. And what has happened in all of this is that no public transportation and so on, and we have a lot of low middle income poor communities. There may be hospitals, but people have no money to be able to treatment. And one of the windows that we have, which is the augmentation fund, the Philippine Charity Sweepstake, because we have no lotos because of the lockdown, therefore they have less funds. So unfortunately, they've closed the windows for assistance to cancer patients, both in terms of medicine as well as hospital bills. So those are the very big challenges right now.
Well, thank you for those comments. If I may ask Dr. Dorairaj now, in similarly, the pandemic has introduced a host of stressors on the well-being of the patient and the population, particularly in such a big country like India. How is it similar in India? Because you did mention some very interesting research on behavior and psychosocial stress underway at the moment. How does the policy issue now and the public health drive and approach to managing this situation?
Right. I think the answers could be multiple. So let's take one or two things and explore them. So the COVID-19 pandemic has posed several challenges, and many of those challenges are very similar to what Dr. Auste just mentioned. And I mean, it's very similar. People losing their jobs, livelihood, food insecurity, all those are very, very common. So I think that requires a political approach and a political intervention in terms of improving the lives of people. But in terms of the healthcare itself, there are several changes that will happen. There will be a new normal, and it provides tremendous opportunities in terms of new things that can be done. The first is a lot has been spoken about telehealth and telemedicine approaches, and that will cater to one particular aspect of the problem that we have been facing throughout the last several decades in healthcare in India, because there is a big urban rural divide in terms of access to care. Many of the doctors are available in urban locations, the best hospitals are available in urban locations. So, rural people have to travel even for small problems, minor problems, they have to come to the city, and that can be catered to. But people still argue that there will still be a divide. It will be regressive for rural people because there is an asymmetry. The knowledge of using IT and smartphones is with the urban people, with the rich, with the educated. How will the poor people use? So there is a solution again for that in terms of blended care, where we can have community health workers who are trained, who can ask a few questions and get people connected to a doctor at a remote location. And so that's the second kind of solution that can happen. And this is one of the frugal innovations that's happening in India. The other big challenges is regulation. Regulation is still evolving. There are lots of unaddressed questions in terms of regulation, data protection, data privacy. How do we do that? All those kind of things requires a close look, and that's kind of going on at the same time. In fact, the Prime Minister of India launched the National Digital Health Mission on the day of independence. That's August 15th, and that has several solutions. There's a blueprint that's available for people to read. But what I perceive is that there will be a large amount of resistance from senior doctors because they are little reticent of using IT platforms, and we have all been trained to talk to patients. There is that art of medicine. We like to, make the patient comfortable, talk to them. This telehealth creates that remoteness, and we need to overcome that somehow. So I think what is happening in healthcare is the third thing which you pointed out is public health. One of the things which will become prominent worldwide is public health. There will be more public health professionals, epidemiologists, public health practitioners. It will become more multi-sectoral, multidisciplinary, and I think that's a very good thing. These are some of the good things that can happen. Thank you.
Yeah, I would agree in terms of the multidisciplinary, if I can just jump in here. Because what has happened in hospitals is that you no longer work in terms of the specialty. It's like if it's a COVID hospital, then everybody really becomes part of the care of the patient. And in a sense, for cancer care, we've always said that an essential part of good survivorship and very positive outcomes is multidisciplinary care. So in a sense, like the good doctor from India was saying, this is now the practice time where it's actually happening. And as well with the digitalization, that even patient support, where before it was face-to-face activities or face-to-face meetings, now we have created Viber communities, or we're doing weekly check-ins utilizing any of the apps that you have, from Google Meet to Zoom and so on. But one of the main challenges really is being able to help them to develop as well. They're being more comfortable with the technology. And this is where actually millennials and grandchildren or younger neighbors help. With instances where they say, wait, I have to go run because my neighbor is the one that knows how to set this up. Then I can join this particular group. But the same is true even for doctors as well, that it's the younger generation, in a sense, that is helping us to maximize the use of technology. So in a sense, I think that's the gift of COVID. We were pushed ahead.
Yeah, I think, thank you very much for those very important comments. And then if I can ask Dr. Huang now, in China's experience, because you have now managed to control the condition, do you see patients now coming back to the hospitals to continue their treatment or their management of their non-communicable disease like diabetes, hypertension, and cancer? Or do you see that the patients are worried to come to hospital until they are present with too late or too advanced disease?
Thank you. When the epidemic started to ease, although the number of severe patients increased in clinic in our hospital, however, the total number of visits did not increase significantly. The total number of patients did not increase. Why? On the one hand, some patients with mild symptoms such as cold, diarrhea, headache, toothache, etc., did not go to the hospital because of the fear of cross-infection. And on the other hand, medical insurance institutions and hospitals have introduced some measures, such as increasing the number of drugs prescribed to reduce the number of patients going to the hospital. Yes, and they also expand more online channels for consultation and drive prescription online and other services. So the number of patients to hospital can significantly reduced by these measures. And doctors can concentrate their energy or can spend their time to deal with the critical ill patient. So the whole situation in hospital in China is very well, I think.
Okay, that's really good to know and quite reassuring. But how would you prepare for if there was another surge in cases in China?
Another surge?
Yeah.
The COVID-19 patient?
Yes.
Patient? Yeah,
yes.
That's our concern. Because every day there are several COVID-19 patients import from other countries. Because the most area of China, the most population in China is not infected by this disease. So we have no immune capability. So we very worried about the situation. So we will rely on the vaccine development. And now in China, there are more than 10 kinds of vaccine is under development. And maybe this winter and this year, the vaccine will be succeed. Yeah, thank you.
We look forward to that as well. I mean, can I ask Dr. Dorairaj in India, your population sequence a little bit different because you still have quite a number of new cases every day for COVID-19. In this situation, do you see that the cases that patients only come to hospital with NCDs at a very advanced or a very acute stage more than before, or is it still the same?
So actually, we don't have an empirical data and people are collecting the data, but anecdotal data suggests that people are coming with complications or coming in severe conditions, particularly as I mentioned earlier, patients who have, they would tend to ignore going to the hospital because it is difficult reaching the hospital. I can cite a survey or a registry that we published in Lancet in 2008. And we looked at what is the mode of transportation for people who have acute coronary syndromes. And we found that nearly 50-60% of people use public transport. Now that we don't have metro rail services, the public buses are not available. It's difficult to get a taxi. So it's difficult for people to reach on time. I'm sure the symptom to door time has increased considerably compared to last year. And we'll get that data soon once we start analyzing the CSI study. And so that's the issue. The other thing is the cases are going up now. And so possibly we will have to reserve more beds for COVID complications. And because of this, there will again be a big hit for NCD related diseases.
Thank you. Dr. Auste, Philippines also have very large metropolis and densely populated areas. Do you see this kind of situation also, like what Dr. Dorairaj has mentioned in India, also in the Philippines, that the patients with NCD are somewhat reluctant to attend to the hospital?
Actually, we're going through of qualitative research of focus group discussions with NCD patients together with the NCD Alliance that we have here in the Philippines. And what we have found out is, yes, there is the general hesitancy to go to hospitals, and not even just to hospitals, like even in terms of the newly opened barber shops, and they were saying nobody's coming to see us like before. So really that general hesitancy to expose themselves to COVID-19. But what we've also found out is part of the coping mechanism is that some doctors actually now do home visits, or else they have opened their homes to become like clinics so that patients can see them there. This is in instances where the patients are not that comfortable just doing an online teleconsultation, but really wants to have some face-to-face interaction. So that is happening. And the other thing as well is that there are smaller facilities. For example, dialysis patients in a particular area that was locked down, one of the biggest malls that we have, they opened up and set up a fully equipped dialysis center so that dialysis centers patients could be going to that center rather than to the regular dialysis center where they were going to. And the other thing as well that we're finding out is that some facilities, again, that were focused on just doing laboratory, because as you know, we have thousands, millions actually of overseas Filipino workers, and so they need this. They have now expanded so that some care or tests or diagnostic follow-up care for NCD patients could be undertaken there. As far as mobility is concerned, Cancer Coalition Philippines decided to offer pick up and drop off. So your pick up from your house, brought to the hospital and brought back home. This was to be able to provide safe transportation mode to patients, because even now that it has opened up, the WHO has said that it would be not advisable for cancer patients and other immunocompromised patients to be taken public health. And this requires drivers as well as resources. So we're able to help, but there's so much more that need help in terms of mobility and transport support, as the doctor was saying.
That's a remarkable effort. I mean, I think ensuring good patient care in this COVID pandemic season requires a real community effort. So what are the opportunities that you have that you can have support networks to keep everyone positive and healthy as they go about their practice to improve patient care?
Is the question for me or for the good doctor?
For you.
What we have done is some of those that are involved in patient support, they now have online. You can do Qigong, you can do Tai Chi, you can do Zumba, you can do yoga. So all of the things that before were not available, or that you had to go somewhere to pay for it, online they are made available. The other thing that the Psoriasis Philippines has done was they are famous celebrities. Every day they had a post from a famous celebrity, inspiring and boosting the morale and sending feel-good message to all psoriasis patients all over the Philippines. Animations and those that are in the cultural and entertainment have done is we now have a series of very uplifting Filipino songs recognizing the heroism of the frontline workers and saying that, yes, they are frontline, but those of us who are staying home, we also are homeliners. And therefore, part of keeping everybody safe is stay home if you don't need to do anything important.
That's remarkable. I'm gonna ask Dr. Dorairaj in India, the Public Health Foundation, and how does your foundation also contribute to the community effort to keep the healthcare professionals in good spirits and healthy while they look after the patients at NCDs?
So I think Public Health Foundation of India has got multiple roles. It supports the government in terms of helping in the modeling, in terms of planning. Many of our colleagues are in the task force for COVID in India. The second thing is in terms of creating awareness, there are a lot of our leaders who write articles in the lay press, appear on the TV and provide advice in terms of public health messaging for COVID as well as non-COVID illnesses, particularly cardiovascular diseases and others. The third is in terms of planning. Also, several of our colleagues help the state governments in terms of planning for how to apportion the beds and how to look after patients with NCDs and CVD or other infectious diseases. So those are the kind of things that we do help. We also are involved in several research which involves implementation science as well as research that involves looking at behavioral aspects of people, the socio-demographics of people, and so on. It is funded by various organizations and various bodies, and we are part of those research. I think this is a broad brush of what we do.
Thank you very much. Now I have two questions for Dr. Huang. The first question relates to the opening up. As you know, China was one of the first countries to reopen their economy. And how did China provide the platform to reopen the economy as far as the community is concerned without getting a corresponding rise in the COVID cases?
Thank you. I think the COVID-19 has changed the whole world and makes the world more complicated. My opinion is only by keep the COVID-19 under good control can we fundamentally solve a series of problems such as social problem, economic problem, and personal problem, because these problems all derived from this disease. Therefore, we must take strong measures to control the epidemic in the shortest possible time. As for the community, you mentioned the community, right?
Yes, and how does the in terms of public policy in China government any special measures that they take to tell the population what to do when they reopen up all the or most of the sectors of the economy?
Okay, actually, up to now, even now, the population gathering is not allowed, such as academic meeting, in cardiovascular disease, such a meeting is also online, mainly online, because a large population is not allowed to gathering. So I think this is very important. We still be alert for the disease.
As you reopen the economy in China, maybe you could share with us in terms of the strategy to reopening schools for young children, and what was the steps taken, and when did you decide to reopen schools?
Reopen school when there is no new cases in a region, maybe for more than 2 weeks, we will reopen the public places step by step, such as school, such as camera, such as factory, also including some large and other places. And we will take the temperature. We will take the temperature at the door in every institution, such as school. And we will report the temperature of every person every day. If we suspect a person with fever or with cough, we will test him.
Thank you very much. And now
Thank you.
can I, coming towards the back end of our session today, if I may ask, just touch on the issue of vaccines. Dr. Dorairaj mentioned in India a few trials of vaccines for COVID-19 have begun. May I ask you, in terms of your opinion about patients with chronic conditions, how would you or where would you prioritize the vaccine use as far as the population subset is concerned?
I think in terms of vaccine, the first would be to high-risk subjects, which means the healthcare workers. The second are people who are older, and the third are younger people with comorbidities such as hypertension, diabetes, obesity, cardiovascular disease, post-bypass surgery, people with renal diseases, people with cancers. So I think these people will be getting it once we prove that the vaccine is safe. So this is what it would be.
Thank you. Dr. Auste, may I ask your opinion on the vaccine strategy in the Philippines? And where would you fit your oncology patients or patients with cancer in this patient or population subset?
Currently, the president himself has identified those that will be priority once a safe vaccine has been tried and is ready for rollout. And the priorities would be healthcare workers, government officials, and those working with, especially with key government institutions, the military and the police, because of the necessity for ensuring the safety and security. And then you have the vulnerable population, particularly elderly. However, with those who have certain other conditions or possible comorbidities, I think there's still a divide. There are certain members of the medical community who feel that it may be unsafe for them to go through and be part of this first round of vaccines. And there are those that would opine that that's the only way to be able to keep them safe. So that is not clear yet in terms of patients. But all of the other sectors that in a sense are considered as frontliners, essential to health, safety, security, and education will be there. As far as our opening of classes is concerned, it was supposed to open for the public school system in August, but it was decided by the government to, in an abundance of caution, move it to October, middle October, even if we will actually not be having face-to-face classes. We will be having blended learning, and face-to-face classes will only happen in the very low-risk areas where there are little incidents of COVID-19. In other areas, it will be through use of media or radio or television or certain materials being brought to the houses of the children by members of the community, the barangays that we have, or even in some areas, the military and the police have already volunteered to be the one to bring it to the houses of the kids and the families. One last point I forgot to mention earlier was also a whole focus on nutrition support for our patients while the COVID is undergoing. And this is either in direct form of cash aid for nutrition or providing information about cheaper, affordable, but healthy food during this time of COVID to make sure that their immunity is kept strong.
Yeah, thank you very much for this comprehensive answer. Dr. Huang, I think a lot of us around the world are very interested in China's vaccines and also the vaccine strategy. So maybe you can share with us when the vaccines are made available, especially as early as this winter, how would you design your vaccine strategy, and who would get it first?
There are a lot of, maybe more than 10 kinds of vaccine are developed, maybe more than 20. There's so many companies to develop the vaccine. And I think this step is very, very fast. At least this winter or the next spring, we will commercialize the vaccine. And the first population maybe include the medical staff, especially the most dangerous population who has the risk to contact the COVID-19 virus. And you know, the COVID-19 mainly happened in Hubei province, and other 23 province, there are very, very little population affected. So the population is very, very large for the candidate for the vaccine. So I think the first population who will receive the vaccine is the medical staff, I think.
And after the medical staff, who do you think should get it next?
Next, I think it's depend on the number of vaccine. Yeah, it's such as the staff of the plan company. Actually, as a medical staff, as a doctor, I'm very concerned of the safety of the vaccine. Because many vaccine produced now, such as the vaccine in Russia, the clinical trial is not so completely conducted. So it's my main concern for the safety, but not its effectiveness. The safety is very, very important, I think.
Can I take the opinion from Dr. Dorairaj in India? And in your experience, how long would you require safety data before India would select prioritize a vaccine for COVID-19?
I think it's not only about the data, the safety. Right now we have finished phase 2 trials which attest to the safety. So I think when you look at vaccine, the three things that are required: one is the safety, the second is the efficacy, the third is the effectiveness of that vaccine across the population, and the fourth is the capacity to provide access, the capacity to distribute across the country. I think these are the things which are far more important. So India has had a rich experience in vaccination because they have quite a good network of community health workers who provide these vaccines all across the country. So my own feeling is, in India, if suppose let us say that we approve a vaccine by the end of this year, a majority of the people can get vaccinated by 9 to 10 months. So that's and if you have that bulk number. And Serum Institute of India, which is looking after the Oxford vaccine, is promised to manufacture that number of vaccine. The ICMR has also promised that they will manufacture huge numbers of vaccine, maybe 1 billion vaccines. So that kind of capacity is there to manufacture.
This is amazing information coming from India as well. And I think if I ask Philippines, Dr. Auste in Philippines, in terms of the safety data, what sort of a safety data period before the Philippines regulators or the government decide to adopt the vaccine for COVID-19?
We have not yet started those discussions. We are very much focused on ensuring first the quality and the rationalized way in which we're able to do the vaccine trials. However, I think a bigger problem that we have already started to discuss is the financing aspect of the vaccines. I agree with the framework in terms of the four things that you need to look at to be able to prioritize it. But then a very strategic part of that, while we're very much smaller than China and India in terms of population, we only have about 120 compared to their 300 billion. But the reality still is, even now, we already have civil society organizations that are having a series of advocacy calling out to government to ensure that there is equitable distribution of vaccines when they are made available already. And of course, the major challenge to us, and I guess to other low income countries and low middle income countries, would be how much funds we still have that can be allocated. Although our president has said that he's willing to sell government assets just to be able to provide as much as is possible. And in that context, actually, as defined, we have 20 million very poor Filipinos that are below the poverty line. And these are actually part of that priority group that's supposed to get it for free. So I was saying the others that can afford, then they can afford to pay for the vaccine. But that's one part of the strategy still already being prepared and discussed, the financial side. And I think for countries that are in low resource settings like ours, that would be a major decision point as well.
Well, definitely the economic considerations would also play a role in deciding our vaccine strategy at a national level. And I think with that, I think the management of chronic disease in the context of the COVID pandemic gives us a lot of other questions that we need to consider beyond our normal day-to-day clinical practice. So I think as we are coming to the end of this session, I'd like to thank Dr. Huang from China, Dr. Dorairaj from India, and Dr. Auste from the Philippines for a wonderful discussion as a panel of experts for this ACC and NCD Academy, as well as the NCD Alliance and the World Heart Federation. I think on behalf of all of us, we thank you for your time and have a good day and good health. Thank you very much.